Okay, so I decided to do my presentation, my honors option on anabolic steroids in bodybuilding, or with an emphasis on bodybuilding specifically. What are anabolic steroids? Anabolic steroids are synthetic hormones that help keep the body in an anabolic state. They imitate natural androgens such as testosterone and DHT, or dihydrotestosterone, which are male sex hormones. They're called male sex hormones because they are predominantly seen in drastically higher concentration in males than in females. They're called anabolic androgenic steroids because they have both of these kind of effects on the body, and they're used both clinically and recreationally, and they're classified as PEDs, or performance enhancing drugs. Testosterone and DHT are called male sex hormones, but they are also found in females, because even though females don't have testes, they are still produced by the adrenal glands on top of the kidneys. So when were anabolic steroids invented? Testosterone was first synthesized by German scientists Adolf Butenandt and Leopold Ruzicka independently in 1935. During World War II, German soldiers were reportedly given testosterone to increase their performance and aggressiveness on the battlefield. And on the right, you can see Adolf Butenandt, and the bottom left, you can see Leopold Ruzicka. The history of anabolic steroids. In 1940, testosterone began to be widely used in competitive sports, but there were no clear unwanted side effects yet. In the 1952 Olympics, the Russian weightlifting and wrestling teams dominated these sports, primarily due to their use of synthetic testosterone. And by 1958, Dianabol, or D-bol, was released by a major US pharmaceutical company, Ciba Pharmaceuticals. In 1975, anabolic steroids were banned in the Olympics as a response to the negative side effects that it has been proven to have, as well as the ethical issues associated with anabolic steroid use. History of anabolic steroids continued. During the 1970s and 80s, it became widespread. In 1990, possession of anabolic androgenic steroids without a prescription was made illegal within the United States. So who uses anabolic steroids? Anabolic steroids have both medicinal and non-clinical relevance, as they are not always taken for health reasons. Anabolic steroids are intended to be used to treat patients suffering from medical problems that cause or are caused by abnormally low levels of testosterone. However, they are commonly used by professional athletes, such as bodybuilders, weightlifters, and wrestlers, to improve their lean body mass and muscle strength. Why were they used in sports? They were used to gain an advantage in competitive events that seem to require ever-increasing bulk and strength, as well as muscle size. The drugs allow athletes to train harder with less rest because the muscle strains and tears seem to repair themselves faster. And of course, peer pressure is a drastic or a primary reason for their continued popularity. All you want to do is be a champion, and you take what anyone else is taking. This is a quote by Arnold Schwarzenegger, who was obviously a famous bodybuilder and still is famous today. This quote exemplifies the importance of peer pressure within the bodybuilding space. What is the function of anabolic steroids? Anabolic steroids are any naturally occurring androgen or synthetic testosterone derivative that binds to the androgen receptor. The point of injecting oneself with an anabolic steroid is to artificially supply the body with an exogenous source of androgens that can bind to an androgen receptor to elicit a desired or unintentional undesired effect. Exogenous being an external source of the body and not natural endogenous production. How are steroids taken into the body? Steroids can be ingested via a number of different ways. They can be taken orally or through the mouth. They can be injected intramuscularly or into large muscle groups such as the gluteus maximus or shoulders, which are the most popular methods for intramuscular injections, dermatologic gels or creams. And typically the doses used by people misusing these anabolic androgenic steroids is often 10 to 100 times higher than the dose used to treat medical conditions. Generally, weekly doses of 300 milligrams or more are injected by these bodybuilders to elicit a blood composition of roughly 1,000 nanograms per deciliter of testosterone. Pathology of the anabolic steroid. Once these steroids enter the body, an anabolic androgenic steroid will travel through the bloodstream to appropriate target cells. Steroids are lipid-soluble molecules, meaning that they diffuse easily through the plasma membrane and into the cell. There, they bond to androgen receptors and are translocated into the nucleus via a nuclear localization signal, where it then acts as a transcription factor on the DNA polymerase. Structure of the androgen receptor. The androgen receptor, without getting too much into biochemistry, the androgen receptor consists of three main functional domains: the N-terminal transcriptional regulation domain, the DNA binding domain, and the ligand binding domain. The androgen receptor is ligand dependent and primarily binds to the leucine and phenylalanine residues on DHT dihydrotestosterone. Binding to the androgen receptor. Binding to the ligand binding domain of the androgen receptor causes a conformational change, which in a sense locks it in place. This conformational change also allows for optimal interaction with the transcription machinery for upregulation or downregulation of specific androgen receptor mediated genes. Use of two zinc fingers as a binding domain to the androgen receptor to the regulated androgen receptor regulated genes in the DNA, which tends to be, in terms of testosterone, is the promoter or enhancer regions of the DNA. How does the androgen receptor affect transcription? Within the androgen receptor are a number of different signal sequences. The ligand independent AF1, located in the N-terminal domain, is required for maximal activity of the androgen receptor. There's also the ligand dependent AF2, located in the ligand binding domain, which forms co-regulator binding sites, which regulates interactions between the N-terminal and ligand binding domain. The transcriptional activity is then regulated by the co-regulators, which can either be co-activators or co-repressors. Effects of androgen receptor activation. Androgen receptor activation can target skeletal muscle, which leads to stimulation of protein synthesis, which means a buildup of protein or larger structures and less breakdown. Targets Sertoli cells, which stimulates spermatogenesis in males or sperm production. Targets the brain, which increases libido, and it also has androgenic effects, which are things such as pubic hair, deeper voice due to the growth of the larynx, and body hair. Androgens are regulated by the negative feedback mechanism. So by injecting testosterone, the body responds by decreasing or stopping natural testosterone production altogether. This leads to something called hypogonadism. What is anabolism? Anabolism is defined as any state in which nitrogen is, specifically for bodybuilding and muscle building, anabolism is defined as any state in which nitrogen is overall positively retained in the lean body mass or fat-free mass. Aggregation of amino acids to proteins is typical of anabolism, and this is done through less protein breakdown or catabolism, or through protein synthesis, which is anabolism. Anabolic steroids are defined by this change in metabolism. Since most people who take anabolic steroids are looking for the hypertrophic or hyperplasic effect of the steroids to build bigger muscles, I feel like it would be beneficial if we just briefly cover the two different types of ways that we can build muscle in our bodies. The first method, hypertrophy, occurs through an increase in the size of the individual muscle fibers. Specifically, as you can see in the middle row on the figure to the right, you can see the actual cells are physically larger than how they were initially. This is called hypertrophy. Hyperplasia occurs through the increase in the number of individual muscle fibers. As you can see on the bottom row, compared to the top row, there are physically more individual muscle fibers, and anabolic steroid use has been shown to induce both of these results in bodybuilders. Consequences of increased androgen receptor activity. While bigger muscles and a faster metabolism sounds fantastic, there is a catch. Of course, with anything external from the body, there's usually some sort of side effect, and in this case, there are several. There's no shortage of negative consequences associated with anabolic steroids. There's an increased risk of prostate cancer in men. There's alopecia or balding, acne, bloating, and body hair, hepatic damage or liver damage, cardiovascular issues or cardiac hypertrophy or enlargement of the heart, or megalocardia specifically, gynecomastia, which is an increase in the development of breast tissue in men, erectile dysfunction, which is self-explanatory, and this is a typo. I meant to say decreased serum HDL cholesterol because there's actually lower HDLs as a result, as well as cerebral effects. And in women specifically, there's polycystic ovarian syndrome, and there are also menstrual changes that are associated with increased activity due to steroids. Quantitative effects of anabolic androgenic steroids on muscles. Injection of 600 milligrams of testosterone in adult males who did not even exercise resulted in an increase in strength and fat-free mass than individuals who incorporated resistance training but only took a placebo. This is insane because it basically says that testosterone alone without resistance training results in an increase in muscle mass regardless of exercise compared to those who just naturally exercise. This is shown by the data, which basically indicates that there was an increase in muscle strength by around 19 to 21% in the group that only took testosterone but did not work out at all. And within the group that took testosterone and exercised, there was an increase of 38% in muscle strength. Within fat-free mass increased roughly by an average of 6.1 kilograms in the exercise plus testosterone group compared to only 2 kilograms in the exercise plus placebo group. And increases in fat-free mass imply increases in muscle mass. Another study showed the impact of stanozolol, or Winstrol as it is marketed as in the fitness community, is a synthetic steroid that is derived from testosterone that has been shown to significantly increase type 1 muscle fiber size, hypothetically leading to hypertrophy of type 2 muscle fiber size as well. Type 1 muscle fibers increase an average of 4.6 microns in length, which is roughly a 10% increase in size. Type 1 is the endurance fiber. So for long, like postural muscles, for instance, that are meant to keep contracting for long periods of time. And type 2 is a fast twitch fiber, which is meant for anaerobic or strength exercises, which is most useful for things such as sprints and lifting heavy weights for repetitions. As you can see on the table on the right, there was a significant increase in micrometer length for the patients treated with stanozolol compared to the control groups. This is just a diagram that basically shows both the positive and negative effects associated with anabolic steroids. There, on the left side, you can see the positive effects, which are increased muscle mass, anabolic effects such as osteoporosis, which are used to treat osteoporosis, anemia, and chronic kidney disease, and the androgenic effects, which are increased libido. There's also the supraphysiological doses, the negative effects, which predominantly affect organs and tissues, specifically brain and behavior, hematologic consequences, which is the blood, hepatologic consequences, which are the liver, musculoskeletal system, cardiovascular system, renal system, reproductive system in both male and females. Neuroscience of anabolic steroids. Studies have shown that anabolic steroids have a detrimental impact on the mental health of those taking them. These changes can be morphological and behavioral, such as aggressiveness, changes in neuronal histopathology in rat brains. Impacts are dependent upon the characteristics of the user, and anabolic steroids are typically taken by those with a body image disorder and are used for aesthetic purposes. This is from a study done on rats to determine whether or not stanozolol had apoptotic effects on the brain, notably the hippocampal CA1, 2, and 3 areas. It was stained using a tunnel assay to observe apoptotic cells in the control rats and those who received the stanozolol injections. Total positive cells are indicated with dark brown nuclei, and the images on the right show two of the separate CA areas that were stained using the tunnel assay in this study. Results of the study. The results show that the mean number of apoptotic cells in the stanozolol group versus the control groups are conclusive with the hypothesis that stanozolol, which is an anabolic steroid, has a statistically significant impact on the mean number of apoptotic cells in each brain region. Stanozolol induces neuronal histopathologic changes by inducing death, cell death, or apoptosis in the hippocampus within only 28 days of use. Hematology of anabolic steroid use, or in the blood, anabolic steroids have been linked to directly lowering HDL lipoproteins in the blood, which are responsible for carrying cholesterol to the liver for excretion. HDL is good cholesterol, and LDL or VLDL are bad cholesterol. There was a decrease of roughly 27% in the group that self-administered the anabolic steroids. Lower levels of HDLs are linked to increased risk of heart disease and stroke. Cardiovascular effects of anabolic androgenic steroids. Elevated blood pressure is one effect of anabolic steroid use, which is known as hypertension, and increased risk of thrombosis or blood clots, lower amount of heart rate variability, putting them at risk of ventricular arrhythmia, atrial fibrillation due to intra-electromechanical delay, decreased serum HDL cholesterol, which is good cholesterol, by 25 to 27% lower. Less cholesterol is reabsorbed and brought to the liver, which means it has the potential to cause atherosclerosis in bodybuilders and induce myocardial infarction. These effects persist long after the use of steroids has ceased and therefore has a significant impact on mortality. Hepatic consequences of anabolic steroid use. Hepatotoxicity or liver damage is one of the most frequent side effects of anabolic steroid use among bodybuilders. This is believed to be caused by increased metabolic stress or oxidative stress of the hepatic tissues, which is an increase in reactive oxygen species such as superoxide, peroxide, and radical oxygen derivatives. The liver is the primary site of steroid clearance, and it can result in acute cholestatic syndrome or the stoppage of bile flow, hence cholestatic syndrome. Chronic vascular injury or pileosis hepatis, which is essentially just indicating that there is blood-filled cavities distributed randomly throughout the liver, and as well as hepatic tumors, which is self-explanatory as to what it is. This is a diagram that shows the explicit physiological effects of anabolic steroids in both the cardiovascular system as well as you can see, anabolic steroids is linked to cardiac hypertrophy, which causes ventricular dysfunction, which can lead to heart failure, as well as anabolic steroids can lead to lower HDL and higher LDL and elevated blood pressure, which leads to atherosclerosis or plaque in the arteries, which again increases the risk of cardiovascular disease. There's coagulation alterations or the platelets, which causes thrombosis, which is blood clotting. And this also, blood clotting can also lead to cardiovascular disease. Hypogonadism. When the sex glands called gonads produce little to no sex hormones, it is called hypogonadism, induced among former anabolic androgenic steroid users due to the abrupt decrease in plasma androgens following the stopped use of exogenous androgens. Testicular atrophy is present, as well as low testosterone levels, impaired spermatogenesis, erectile dysfunction, decreased libido, and fatigue are all symptoms of hypogonadism. Return to normal body production of endogenous testosterone takes around 6 months to a year. This is essentially caused by when you introduce an exogenous source of testosterone, you are artificially increasing the amount of androgens in your body, and your body is a finely tuned machine and it knows what the natural limit is for your specific body needs. So when you have a super physiological dose of testosterone, your body needs to limit the amount of testosterone circulating within your blood, and it does this by converting the excess testosterone into estradiol, which is an estrogen derivative, which causes female secondary characteristics, and this is what leads to something called gynecomastia. When one artificially increases their testosterone levels beyond natural limits, the body, like I said, must attempt to control the excess hormone. Gynecomastia, or enlargement of the breast tissue, or development of breasts in males, is characterized by the overabundance of estrogen in males. Once in the body, steroid hormones from anabolic steroid use is converted in part to estradiol, which is a type of estrogen hormone that results in female secondary characteristics. And as you can see on the right, I have an image of Ronnie Coleman and Frank Colombo, which both have had gynecomastia, as you can see on the picture. Quite not as bad as the diagram on the bottom, but it is still very apparent. Gynecomastia continued. Estrogens are generated mainly by the action of aromatase, which converts testosterone to estradiol. This is done mainly by aromatase negative HeLa cells and NCF7 cells. And again, this converts testosterone to estradiol. The synthesis of estrogenic steroids was blocked through the inhibition of conversion of testosterone to DHT, showing that estradiol estrogenic steroids are products following the formation of DHT, or dihydrotestosterone. The combination of 5-alpha reductase inhibitor, which converts testosterone to DHT, and an aromatase inhibitor may limit estrogenic steroids and decrease the prevalence of gynecomastia in anabolic steroid users. As you can see on the flow chart on the right, you can see that testosterone is converted to DHT by 5-alpha reductase, and you can see that testosterone is converted to estradiol via aromatase. Conclusions are: don't do steroids. It is probably not worth it, even if unless you are a professional bodybuilder and you have and it's your work. I would not recommend it to anyone, strictly for aesthetic purposes. These are my citations. I included a lot of the citations on my individual slides because I felt like there was not enough room here to show them all. Thank you.